So today we're going to be focusing on the use of routinely collected data. And the article that we're going to discuss today is just an example of the type of question that you could answer using existing data. Which gets us to this study. So this study, which was looking at treatment outcomes of MDRTB patients in Lesotho, used entirely routinely collected data. So I want to give you a little bit of background, and then we're going to spend some time focusing on the results. So there are high rates of MDRTB and HIV co-infections in Lesotho. And traditionally, individuals who were co-infected got the MDR-TB treatment first, and then they got the HIV treatment. So people were worried about having both drugs. I'm sure you know more about the treatment process than I do, but they were worried about giving them both treatments at once because of the drug interaction. So they got the MDR-TB treatment, and then they got the HIV treatment. But they found that there was a lot of mortality in this group. A lot of people were dying while they were waiting to go on HIV treatment. So the Lesotho program was a bit different, where they immediately started co-infected patients on HIV treatment. So instead of doing MDR-TB treatment and HIV treatment, they did them at the same time. And the question of this study was, what are the outcomes of these patients? And do the outcomes differ by HIV status? So is there any benefit to giving them HIV treatment and MDR-TB treatment at the same time? So I want you to spend a little bit of time going back to the article, and I want you to look at the methods section and talk about in your groups who was eligible for this study and what were their data collection procedures. So 15 years plus, MDR-TB positive, and this had to be confirmed. Now, Amable said HIV positive. Did you have to be HIV positive to be included? No, they also included HIV negative. Okay, because the primary question, Amable, is to compare those who are HIV positive to those who are HIV negative. So you're right, they did have to have MDR-TB, but they allowed for both co-infected and for not co-infected patients. So these are the individuals who were eligible, the patients that were getting treatment for MDR-TB, the cases were confirmed, and they were 15 years old or older. How did they get data on these people? Where did the data come from? So they got the data, was pulled from clinical charts. And there was this word that you should all know, retrospective. They were retrospectively polled. So they're looking at patients who started in the past and collecting data on them to do this study. And there literally was Hinsati, Megan McLaughlin, the authors on this paper were literally doing an extraction from the patient charts to try and collect the data, or to collect the data to answer this question. So I want you to now look at table 1, and I have one question, which is, what factors are significantly different between HIV-infected and HIV-uninfected MDR-TB patients? And then there is a bonus question, which is, and why do we care? Why are they looking at the differences between these two groups of patients? The first question I asked you is, what factors are significantly different between individuals who are HIV positive and individuals who are HIV negative? There are no factors that are significantly different between the two groups. Paterne, how did you answer that question? What did you look at to give you the answer? Okay, so here's my p-value. He looks at the p-value, and Paterne, what were you looking for in the p-value? Okay, so is the p-value less than 0.05? If it is less than 0.05, we say it is significantly different. There is evidence of a significant difference. So I look and when I compare the ages between HIV negative and HIV positive, the p-value is bigger than 0.05, and I say there's no evidence it is significantly different. When I look at time since TB diagnosis, the p-value is 0.2911. It's bigger than 0.05. I say there's no evidence of a significant difference. Okay? So based on this, no factors are significantly different. Question 2, which is a much harder question, is why do we care? So remember, they're interested in is HIV status related to their MDRTB treatment outcomes? And in this table, they are looking at whether or not there are any differences between those who are positive and those who are negative. Why? Why do they care whether or not there are any differences between those who are positive and those who are negative? So they're interested in, is age different in those who are HIV positive? Because age may also affect treatment outcomes. So they are interested, is age related to HIV status? And they'll eventually look, is it related to TB status? So they're interested in this relationship here. What are they trying to look for? What does this picture make you think of? Maybe. Confounders. Are there any factors that are related to HIV status that might confound the relationship with the outcome? That is what Table 1 is trying to do. Are there any differences in my exposure group that might confound the relationship between my exposure and my outcome? So there are no factors significantly different between those who are HIV infected and those who are not. And essentially what they're saying is we are not too worried about these being confounders. We are not worried that these will confound the relationship between HIV and MDRTB. Now you'll see that these are based entirely on routinely collected data. Maybe income is a confounder. And if income was not available, they cannot see if income is different between those who are positive and negative. Next question. Based on Table 3, what can you conclude about the impact of HIV on the outcomes in the MDRTB program? So specifically tell me, based on Table 3, what do you think this relationship is? There is no difference between the groups. There's no evidence of a significant difference. Perfect. Ansil, what did you look at to give me that answer? So you looked at the confidence interval. And what did you look at in the confidence interval to say there's no evidence of a significant difference? It covers 1. In this case, we're looking at the hazard ratio. So remember, a hazard ratio of 1 means there's no difference. This hazard ratio is not equal to 1, but the interval does cover 1. I don't know the truth, but what I think covers the truth is covering 1. So I say there is no evidence of a significant difference. We look at this and we say, we thought HIV status might be related to TB outcomes. But when we did our test, we concluded that there is no evidence of a significant difference between the two groups. That there is no evidence of a significant difference between those who are HIV positive and those who are HIV negative in their TB treatment outcomes. And this was a very important finding because it's part of the conversation about, remember I said most places have MDRTB treatment and then HIV treatment. Lesotho was different because they had the treatment at the same time. And this is one of the research that contributed to the conversation to change treatment to have them at the same time. Where we now, the protocols are to treat individuals with HIV at the same time for both HIV and TB because we see better outcomes in those groups. Now remember, no study is perfect. So one problem was some patients were missing their DST, their drug sensitivity test results. And those patients, they just had to drop from the paper. We actually, in the first version of the paper, had them included, and the reviewers came back and said, you must remove those patients because we don't know for sure that they have MDRTB. Another limitation was they were missing height on 10%, albumin levels on 22%, hemoglobin levels. So there was some missing data, and they had to have solutions of how to address that data. So it is not a perfect study, but we can still learn valuable things despite the imperfections.